About our session this afternoon. Just before this meeting today, I was at the kickoff inaugural meeting of the Community Information Exchange National Community Advisory Council, organized by the San Diego CIE and Health Leads. And as we wrapped up the meeting, they asked, what is it that people most want to work on? And in addition to health equity, consent was the other top winner in that group. And there were people from literally all over the country in the midst of improving, building, planning, etc., community information exchanges. And it really points out the dilemma that we have today, which is that right now we all are asked to invent an approach to consent individually with every project that we do. And, it's sort of that go forth and multiply approach. And instead we tend to go forth and wither because it's so overwhelming and it's so challenging that some people actually give up instead of successfully navigating this challenge of how to get adequate consent and how to manage consent that might change over time. So I am really, really excited that we are jumping into this conversation today. We have quite a few people ready to jump in and add to the conversation, but I hope that everyone here in our virtual room will really take part in this conversation. A couple other things that we want to do to set the stage. I'm going to ask Ken Salyards to tell us a little bit in a few minutes about consent to share. And so that's going to help to set the stage. But before that, I wanted to mention that just in the last couple of weeks, one of the things that was encouraging that came from the federal government was a letter that came from CMS talking about the social determinants of health. And what was really helpful there, I think, is that it made it very, very clear from those of us whose starting place is healthcare, which I know is not everyone in the room, but that actively addressing the social determinants of health is part of healthcare treatment. And so for those of you, who know HIPAA, and I should also note that this is a master class. This is not a HIPAA 101, and we'll talk about that as well, nor is it a 42 CFR Part 2 101 or a FERPA 101. But for those of you, who are very versed in HIPAA, the issue of something being treatment is really, really key to it being quite appropriate to share information about somebody. So I, for one, and I know others, were very excited to see this language coming out from CMS. It also opens up the ability to leverage some federal funding. And so those are the kinds of things that we want to talk about today. So I'm going to ask my co-host, Paul, to just jump in and introduce himself here today. Paul and I both are working on these integrated care for kids projects. So Paul, if you want to introduce yourself.
Thanks so much, Christine. Welcome everybody to the group. I'm Paul Meissner. I work at Montefiore Medical Center, where I do research program development for our care management organization and work across many different components of the organization. But the common theme is data integration. In particular, I wanted to frame our conversation today to try to align our abilities to share data with our interests in collaborating across sectors. When we've been exploring this, as we have been doing, Christine and I, and there are other programs around the country with this integrated care for kids, what we've done is we've kind of knocked up against this wall of consent. And what we hope to be able to do here is to introduce many of our speakers, but also to introduce some solutions for you in this. And I particularly welcome my colleague, Kathy Miller, who works with Bronx Rio, which is our health information exchange. And Kathy and I have been collaborating for years on trying to break through on many of these different approaches to consent. And so, really what our group, and as we were planning this, came up with the concepts also that there are lots of misunderstandings and that there's so many different interpretations. And we just want to help clear some of these up so that we can kind of clear the air today and present some solutions for the group. So we really welcome your participation. We do want to make this a participatory conversation here. So please feel free to ask questions, put them in the chat. We'll try to get to the chat also to get the conversation going. So thanks for joining us. And I want to turn it over, I guess, now to Ken and Dan. I don't know if Dan's back with us yet, but Ken's going to present on this concept of consent to share as a utility so that we can all understand how this might be of interest to us. And as a group, we'd like to really hope that people will adopt this concept of the utility and we can explore how to operationalize that. So Ken, why don't you take it away?
Sure. So today we're going to talk about what I refer to as the operational data hub and consent to share C2S. So you can next slide, please. And then, so really we're going to talk about the ODH. We're going to talk about what I put together as our consent theory of operations for the ODH. And then we're going to look at viewing and creating consents. Now, I have my awesome esteemed colleague, Michelle Zancan, that will give you a demonstration of consent to share so that we don't have to look at a bunch of slides to try to get a feel for what it is. So once I stop blabbing, then I will turn it over to Michelle and she'll give us a demo. Okay, so we can go to the next slide. So here we have a picture, and it's not complete by any stretch of the imagination for what people have to deal with from the state and county perspective, from a systems perspective, right? You have all kinds of systems, all kinds of activities that you have to do, from child welfare to referrals, to appointments, to providing services, to care management, to screeners and assessments, to care coordination. You have to put together care teams and so on and so forth. And then at the bottom there, you can see consent to share, where you have to share information from providers and others to facilitate the information content necessary to service a patient at the point of care. So this is just, again, sort of a semblance of the information content that has to be dealt with for people such as Christine, who's doing this Inc. grant and has to coordinate among many, many services across the field. So next slide. So here, our consent theory of operations from an ODH perspective and consent to share is that, you know, in 2017, they changed part 2 to allow a general designation in the from and the to. Previously, it was only the from could have a general designation and the to had to be specific, right? And then they wanted to change it to be the from be specific and the to be general designation. And so I convinced them that taking away general designation in the from and putting it into the to, you know, really doesn't solve the problem all the time. So I was able to convince them to make both general designation capability. So, you know, we built OCP, which is Omnibus Care Plan, which used the construct of a care team, right? So what would happen is that, you know, when a person was treated by many providers, and these providers could be from different organizations, they were made part of the care team. And so the care team became a general designation, as well as the OCP became a general designation. So, you know, when you have systems like this that have lots of people that are doing lots of different things, right? You create a definition of a role, and associated with that role are permissions. So when a person logs into the environment, right, their role facilitates them getting access to information based on their permissions. So, for example, if you had Meals on Wheels as one of your providers in your care team, right, the only thing they could see in the patient information is the information necessary for them to not kill the patient with food, right? So, you know, they would have to know that the patient's diabetic or, you know, has a heart condition or some issue that relates to food, and getting the wrong food can do them harm, not good. So those are the kinds of things that we're talking about when we talk about being able to associate roles with permissions in a care team, such that the roles and permissions control how the information is actually presented. So what we did was the from would contain ODH or the OCP, and the to would contain a share all perspective, right? And well, it was a share all to the care team, right? So the care team now can see the information associated with their role and the permissions assigned to that role, so that you really don't lose any privacy content, because if you're not allowed to see the information, you don't see it. And that's how we put together sort of the back when this was created, the OCP, and how we would move forward again to define what roles and permissions are required for a particular environment. Next slide. So here I'm going to turn it over to Michelle, and Michelle is going to give you a demonstration of consent to share. And so then after that, we can chat about what you saw.
Hello, everyone. Can you see my screen?
Not yet. We're still seeing Ken's. Okay, it's coming.
Yep. There it is.
Okay. So you can see the login screen here that we're looking at.
Yes.
Okay, and thank you, Ken, for the introduction.
Sure.
So today we're going to be demonstrating a very basic workflow of consent management between multiple organizations that would share the care in a single individual. The consent tool, Consent to Share, is accessed as a Smart on Fire launch from the case management tool, the Operational Data Hub, or OCP, which allows for more robust and thorough sharing of data for the patient's care. Our demonstration is in a development environment. So what you're seeing right now is all test data, and it's dummy data. It's not connected to a PHIN or a HIE at this point, or some other type of data warehouse or data store where the patient authentication happens. But in our production environment, it would be connected or can be connected to such a kind of data stack that allows for the patient authentication to happen. In this use case that I'm going to demonstrate today, I chose that we would work with a 19-year-old young man, Thomas Jackson, with a history of substance use disorder as well as behavioral health issues. And he is sent to his high school guidance counselor following a fight in the schoolyard. Following a brief counseling session, the guidance counselor, Ms. Lilly, and Thomas have agreed that he should be evaluated for anger management program, outpatient of some sort, to keep him straight. He's been clean, he wants to stay clean, and this is something to help support him in that effort. At this point, Ms. Lilly will sign into her case management tool to thoroughly coordinate this evaluation with a local guidance counselor, Mr. Sonnet, and begin the consenting process for all of that to happen. So at this point, you're looking at a login screen. I'm signing in as Ms. Lilly. And there is a little bit of a delay with these demonstrations on Zoom. I don't know why, but there is. So Ms. Lilly signs in. This is her, her operational data hub dashboard. Here she's got a list of her clients. She can do to-dos and tasks assigned to her and other members of the care team. All of her clients, she'll have a comprehensive list of the appointments for all of her clients. These are her appointments that she either schedules or attends. And then there's also a calendar view of those appointments down at the bottom. But our focus today is the consent management piece. So if we go into our client, Thomas Jackson, this is the patient record. So this information on here is all specific to Mr. Jackson. And these are his to-dos and the tasks assigned to either him or the other members of the care team. This down here outlines who his care team is, including Frank Sonnet, the counselor who will be working with him, another counselor he saw in the past, Ms. Lilly, who is the guidance counselor, and then another care manager. Obviously, I've used this demonstration before. So then here you've got a very brief place to document communications that occurred, so that the care team is aware of any missed calls or difficulty trying to get a hold of someone or whatever the case may be. And then over here, there's a place for insurance benefits that can be captured if that's appropriate. At the top is just a brief summary of this client, including basic demographic information. And then we have an advisory over here that just lets us know that, that this client has a drug advisory that they could look at. If they wanted to get more information on the advisory, they can see that in the screen down here. He was clean as of the 17th of February last year. So again, just more information on that client. Now getting into your consent piece. So if Ms. Lilly wants to create a consent, she's going to do the smart launch here. This is going to bring us into our consent to share tool, and she will be adding a new consent. As Ken mentioned, this is a very robust consent tool. There's a lot of options. You can do the quick, just make my information available to everybody, click that and you're done. You save it down here. If we have a client, however, that wants to get into specifics about how and when and why their data is shared, that capacity is built into this tool. So as Ken had mentioned, that to share my information is pre-populated with the provider who's going to be sharing that information. And then over here, who I will be disclosing my information to can be chosen. This pre-populates with all of the available organizations and practitioners that are within this system. So if we were to come in here and just pick Mr. Sonnet, who's the counselor we're looking for, and then coming into the next section, again, you can just say, share everything without exception, not worried about it. Or maybe this is a 19-year-old guy. He doesn't really want his sexual or reproductive health shared. And he's not HIV positive. So he doesn't even want that written on there because he's 19 and he's scared of that word. So we change the settings to make him comfortable. Then we go into the purpose of use. Again, it has a default for treatment because that's the most obvious. However, it can be edited, payment operations, so that the insurance company could be billed, emergency treatment, obviously, for obvious reasons, if it's been a patient or a proxy request, or research. Go ahead and complete that section. And then at the bottom, once again, we have a default of a 1-year term. However, this is also can be edited. So it'll start today. And let's say for whatever reason, he only wants it to be a couple months. Okay. Any questions here? Okay. So then in this process, this would then be saved. We'll see here, we got a message that that our consent was saved. And then Miss Lily will have Mr. Jackson sign in to the same dashboard using his own login. So as a patient, he'll be logging into this operational data hub. He'll have a very similar dashboard, but this is all just obviously specific to him. These are the tasks that he'll have to do. These are his pending appointments that he's accepted, his insurance information here. And then over here, he has an additional screen where he can add in related persons. So his mother, Tammy, would be here, or if this were someone who had mobility issues and they had someone who drove them or a caretaker, that information could be put in here as well. So Mr. Jackson, now going along with our workflow today, is going to go in, open his consents. And now here, you're going to see a list of all of his existing consents. These are all of his existing consents. This is the draft one that we just created. Let's see by today's date. But then here's an inactive one when I was practicing yesterday to do this demonstration. These are all inactive here. You've got some more active ones down here. So at any point, any of these can be revoked or activated. There can be multiple, depending on how specific the client wants to get with who they're sharing their information with. If you do this as kind of like a more detail, less detail, just to get a general idea of what's going on with each of these consents, so you can narrow down to the one you're looking for. But this one we know is the one we're looking for because it's in the draft state. So if I click here to manage consent, the patient has the option to edit this consent, which will bring you back into this field, and then you can go through and edit whatever he wants to edit. He will also have the option of signing this consent, which we'll do in just a second. He can preview this consent, and this puts it into a printable document that outlines all the details if for whatever reason he needs it to be in a hard copy format. And then delete. So there's his option to revoke, is by deleting the consent. At this point, because it's draft, it's delete. If it's an active consent, then his option, oh wait, that's not the one I went in. If it's an active consent, then his option is to revoke. Any questions at this point? Okay, so back to our draft here. Oh, there's some in the chat, but
there's actually a question about minors. How can I manage consents for minors when there are a number of providers and multiple family members and number of providers?
Ken, do you want to take that? You're on mute. 2020 hashtag you're on mute. How many times have we done that?
It was more a question of getting back to the thing where I can unmute myself. But at any rate, how would I manage consents for minors when there are a number of providers and family members involved? I'm not actually sure exactly what the question is.
That was my question. I'll expand on it. So in California, you know, under 18-year-olds have hold their own consent, and then there are many providers who will not share information if they are not given some type of permission process. in order to be a part of the care team. It's one thing for an adult to be able to go through and give permissions. It's another for when you have a complex amount of care, providers in different groups that are providing care for a minor to be able to manage consents. So
Right.
does that help
And-
clarify?
Yeah, so I mean, basically, it sounds like you can't share information about a minor without their consent, right?
Yeah, that's one thing, like health benefits. And if you're a minor in California, 13 and above, you have some privilege over your own medical records. And then you have family members who have control over records too as well. And then you have behavioral health, who's interested in protecting, confidentiality. And so how do you go about looking for consents in that area, that arena? So if you want to have a view of being able to provide a robust level of services for a minor, which go across even the educational consents too as well. Who controls educational privilege, right? Is another thing in California that's different, and I don't know in different states and whatnot. But just wondering how this process, it can work within a rather large system across for children in particular.
Sure. So basically, you can create a consent that's from one individual or organization to another individual or organization, right? So if you're a physician, the patient, who has control of these consents, whether they're a child or not, right, could create a consent to say, I want to share my information from, the doctor I'm seeing now to another physician for some other condition or whatever, and say, I want to share this information from this physician to that physician, and only that information then would be exchanged, right?
And
So
this is Christine. So in addition to that, can we also add the parent to the care team and not allow this information to be shared with the parent? Because I think we have both issues. The issue of the adolescent being able to give the permission to share it, but also the issue that the adolescent may not want their parent to have access to this particular information.
Sure. So you could create a parent role, right?
Yeah.
And then that role would not be able to see information that the child, at the age of 13 and beyond didn't want
Great.
them to see, right?
Great.
So, their sexual habits or whatever,
Right.
drug taking, et cetera, et cetera. In California, they just made that, such that without a consent, you can't share the information.
Right.
And if you don't consent that information to be seen by your parent, right?
Yeah.
Then
No, I think that would solve the problem. So
That's right.
we just got the 30-minute warning on our
No,
session
that's-
here. So I'm going to see if we can have Michelle pick back up and finish our demo so we can keep moving along. But this was the minor discussion goes to the heart of my project. So I'm happy to have had it.
I do want to just make one legal note that in California, it does apply with the age for FERPA, which is 18. There is no additional law that reduces that age for consent. So parents are still able to access student education.
Right. If it happens within the school. Yes.
Yes, within the school. Yes. But
Yeah.
for medical treatment, yes. 13 is a very common age in other states as well. That students minors have
Minors, but not
yes,
students.
minors have the ability to consent to treatment and to hold their medical records confidential even from their parents starting
Sure.
at that age.
And that's also in Ohio too. Ohio's similar.
Yeah,
Yeah,
I mean, the question then too is where the juvenile court comes in terms of privilege and offering privilege too as well sometimes is also a rather unique, issue with minors too as well.
Yes, it's definitely unique, though there are often exceptions in the law for judicial proceedings. And so a lot of that comes into play there.
It
Great. Well,
really,
maybe we'll
I'm a
ask Jennifer
judge
to
in the
talk
juvenile
a
court
little.
system. Really, the only really exceptions are emergency orders. And so you can manipulate what emergency order is, but I have full control over release of information, ordering medical care when I can justify emergency orders necessary.
Thank you for that clarification, Tony. That's really
Yeah.
helpful.
And emergency orders typically make the data completely open, right?
It makes the data open to everyone who's, yeah, I guess it does make it open to everybody.
Yep.
Well, I mean, I would say to you that if a child needed emergency care, I could order emergency care and I don't have to disclose it to the parent. So it doesn't make it open to everybody.
Would be open to those that are privileged to see it.
Correct.
I'm not sure where this question goes, but we have a process going in Colorado, the state's running to try to do this in a rational way, standards-based, et cetera. Then we have different players in the market who haven't waited, who have deployed Aunt Bertha or deployed Unite Us. So we're getting a complex ecosystem. What I had understood, Ken, or let me ask you the question, not what I understood. Is this a standalone permissions utility that can be put into a state, managed by the state or some neutral body and serve multiple tools that look like what Michelle was showing us at the beginning?
Yeah, so it's a smart on fire component. It's consent to share is a smart on fire. So any environment that can properly launch a smart on fire app could use it, right?
Let me interrupt for a second. Why don't we let Michelle finish this off, because what you guys have basically done is taken us to our next discussion topic. So let's let her finish right now.
Sorry.
Yeah, no worries. It's a great discussion. So if we're back here with our client. Our client is going to go ahead and sign off on this consent. It gives the client a brief review of what they've agreed to. They sign off very basically and complete. I get a message here telling me that my consent has been successfully signed off, and you can see that my status here changed to active. So now if I sign in as the provider, Mr. Sonnet, who's the counselor who will be doing the anger management evaluation, Mr. Sonnet has now got Mr. Jackson added to his list of clients. He can go into, oh, wait a minute. I'm gonna blame that on Zoom. Go into Mr. Jackson's shared record, if you will, and with all the same information that was available to the other members of the care team. And then can open up the consents and then view here that the consent has already taken place, that Ms. Lilly has consented to share the information over here with Mr. Sonnet. It's an active consent. You can see the details of that consent and then act on it accordingly. And that goes through the full process. It's very simple. I went through it kind of, slow explaining everything, but this is a very easy to fit into your clinical work day when you're working with people, because I think that's a big piece of anything. When you say consent to a medical person, that myself, I'm a nurse, you say consent to a medical person, they go, oh my God, no, don't make me do that. Because it's typically a drawn out process. There's all this explanation. Nobody really understands the legality and the background to it, so they're not comfortable with it. This is a very easy to use system. It's very low burden, and it's very robust.
Great. So Michelle, can we talk a little bit about, configuring it and how it would be configured? And I'll ask Jennifer and Chris to jump in maybe with some questions specifically about configuration relative to local and state laws.
Ken, you might be better to answer that question than me. We have this in production. We're using the consent to share as part of our operational data hub that we're working here in the DC area. And it's with a local government. It's a 5-county program that is going to be using this system to consent with the data sharing within their program, as well as using the case management aspect of the tool to collaborate across all 5 of those counties for the sake of this program. It's funded under that program, but the intent is to roll it out for all programs that would be in the southern part of Maryland, with southern Maryland at some point. As far as configuration, though, I think, Ken, that's going to have to be a you question.
So all of those are in Maryland. It's not crossing into DC or Virginia where you have to work with the different laws potentially.
Not yet.
Okay.
This is Tony. I was going to ask us a question about CAM, which really I think is the same kind of question in a little different way. You know, I deal with my own case management system. I happen to use the Watson healthcare system. And the biggest frustration I've had is, does this system interact so that my staff can put in information one time? So can I transfer information from case management system to this system? The input challenge I had when I went to IBM Watson was extremely frustrating for staff to have to put information in twice. So I want to make sure that these kinds of systems are ones that can interact very simply, and it's built so that it can be linked to a system that most courts already have.
Sure. So the consent to share creates a fire consent. So anybody that can access the fire store can snatch the consent and share it among as many people as you want. The filled out consent, becomes a consent resource in the fire database, right? So it's there to exchange.
I hear that, but in the initial data screen for the dashboard, there's a lot of information that was preloaded into it.
Well,
the preload information needs to be redone again, or just
that's right. So you have, what I would refer to as a fire infrastructure, and so that fire infrastructure, created several base things, right? Organization, persons in the organization, and roles and permissions associated with that person within that organization, and so on, right? So those are things that any infrastructure would have to provide, right? In that regard. Otherwise, you have to, type all that stuff in, or create it from basically nothing, right? So that's what the infrastructure provides. But the consent to share tool can be, again, called by any fire infrastructure that supports consent to share based on the not consent to share, but fire application component, Smart on Fire application component based on the Smart on Fire specification. When we started building this process, right, there were a lot, several organizations that had capabilities to do things and said they were Smart on Fire enabled, right? So, when we launched them, the launch failed, right? Because, you can have Smart on Fire apps that don't have security and so on and so forth, and they launch just perfectly fine, but when you actually launch them using OAuth 2 security and so on and so forth, they failed because they weren't enabled to launch like that, right? And in a production system, there's no way you can have Smart on Fire apps being launched without security, right? So
Ken, let me see if I can take this a little bit back on to and really to answer Tony's question a little bit. So and because what Tony's really pointing out here is that there are some criteria, operational criteria, that they want the programmers and the systems developers to address, right? And I think what Ken's pointing out, yeah, he sort of kind of knows how to do it. He'd have to have a little bit more conversation, but it can be done. I think that what we wanted to really do with this session, though, is we wanted to stay kind of on the consent side and about privacy and confidentiality, and really to point out that on the legal side, there had been a lot of progress. Because you can have a great system, but if the lawyers don't agree on all of the operating permissions and kind of the legal part of this, you're just not going to make progress. So we want to give both Jennifer and Chris Alibrandi a little time to talk about to talk about some common understandings about information sharing, how it can be done from a legal perspective, and also to talk a little bit about the misunderstandings and misconceptions that kind of many people share that have held progress back. So Jennifer and Chris, why don't you guys go?
Sure, thanks. So I guess I want to just say generally that there are a lot of misconceptions that exist around the way the law is structured and what it permits. I work with health departments a lot regarding, sharing information specifically to address things like social determinants of health and care coordination, and the number of people that think that HIPAA is a complete bar to sharing is quite high, and there's just a lot of misinformation. I'm sorry if you hear a few like whistles or squawks. I have a bird and I am at home thanks COVID, so just apologize for that. But as far as the landscape of the law, I think that the real barriers that do exist are related to the fact that we have a federal landscape, but then each state also is able to pass their own data sharing laws, because most of the federal data sharing laws are not preemptive of state laws. And so states are able to make laws that are more stringent or protective, however you want to view that, to implement privacy controls for patient information and other individual personal health information or personal information. I think California is definitely an example of one of the most strict laws in the country, and it in many ways mirrors the European model of data protection, which is a lot more stringent. And the real sticking point that I find most people have is that looking at one state's law and then trying to share information across with another state brings in a lot of complication, because you then have to examine both states' laws and see if they are harmonized and all of those things. And what I would love to see a tool like this do, and what I think would really benefit data sharing generally, would be to stand up these instances of something like consent to share and have each one mirrored based on each state's law, and then have the system basically do a crosswalk of the laws and say, okay, this state permits sharing based on these factors and this state permits sharing based on those, and are they compatible? And in a lot of ways, once a team sets up and a legal analysis has been done, I think a lot of this can be automated. There are lots of systems that already do very similar functions like this in other domains like financial sector and other sectors. And so I think that this is achievable and we have the technology. It's just the legal landscape can be confusing and it holds people back.
Yeah, so it's interesting because typically the from state dictates what you can and can't share with or without a consent, and then the to states just the receiver, right? That's kind of the perspective that this is coming from, right? The from state.
Yeah, States definitely will, provide for restrictions on additional sharing or secondary uses of information in their
Exactly.
laws, and that's really a lot of times where the
And see, with the change in part 2 with the CARES Act, right? Now it's going through HIPAA TPO, so there's no redisclosure clause applying to the information now. So the data can be shared ad infinitum until a opt-out is put in.
yeah, but it's important to note with 42 CFR Part 2, you still need a written consent from the patient to share, even if it is for treatment.
Right.
So it's not an
but it-
unlimited.
But it's considered an opt-in now, right?
Yes,
It's
essentially.
saying I'm just, opting in to share my information, and the information gets shared through HIPAA TPO, so it falls under HIPAA now. But the caveat here is that when I, as the patient, go in and say, oh, I want to revoke my consent, as it were, right, which I'm opting out now, no new data can be shared. And so organizations have to be careful that they in fact know that an opt-out occurred. And so that really has to be done at a national level, if you think about it, because if you don't have some place to go and say, oh, this patient has opted out now, the actual physical sharing of information from that point on. If it's the original information that was shared under the opt-in, it can be reshared billions of times, right? But if you opted out and then they start sharing new information based on the notion that they still think you're opted in, that's a HIPAA breach violation. So it gets a little.
Jennifer, can you maybe just address the fact that, really what the experience is of HIPAA breach violations? I mean, there's this theoretical concerns that we could torture ourselves with and never go to sleep at night. And then there's the reality. And Jennifer summed this up, I think, very nicely in one of our discussions the other day.
Oh, I don't remember if exactly what I said, but I think that
no enforcement actions is what you said.
Oh no! So for HIPAA,
that was FERPA.
There definitely have been enforcement actions under HIPAA, and there are quite regularly. And breach notification has been one area that OCR has been pursuing quite heavily. And so I think it really is important to be mindful of the consent, and when people withdraw consent, though they're, the breach notification rules are really meant to capture mostly when there are like larger violations, when multiple people's information, and then that's when you have to make notifications to the media or to OCR and to other organizations if there has been a breach. When it's an individual person that's opting out their consent, you could still face penalties, but that's more a violation of the privacy rule than the breach notification rule. And so, but I think that and we were having a discussion around this, and I did say, as Chris said, that FERPA actually has had no federal enforcement actions ever. According to my research, I've done quite extensive research, and it doesn't seem it's ever been enforced, though obviously still complying with the law is important. I wouldn't advise anyone otherwise.
And part 2 is the same way, right?
Yes.
I don't believe there exists any case law associated with part 2, simply because of the way the patient had to go about trying to get somebody to pay attention to it, right?
Yeah, there is no private right of action under 42 CFR Part 2, and so any actions would have to be brought by OCR.
Attorney General or somebody.
Or an Attorney General,
2.
yes. You could bring under, an Attorney General could bring an action under the deceptive,
now all you have to do is
deceptive practices.
Right, now all you have to do is report it to OCR, and it's their problem to decide whether they want to do anything about it.
Right. And part of what we wanted to frame in this discussion today was
great.
Sorry, go ahead, Jennifer.
Oh, I was just going to say, do you remember what I said that you felt was so great that I summed up?
I think you've repeated it, and I think essentially it was that when people are prosecuted for HIPAA breaches, it's really these large scale HIPAA breaches that are either intentional or unintentional, but they're not these one-offs. And I think that that's what's really important, because again, I think none of us could go to sleep at night if we worried about every single one of these individual things, because it's not always going to be perfect. The technology is not always going to be perfect. Our audits that we run may be run 2 days too late, whatever it is, something like that might happen. And I think we just have to learn to live with a little bit of uncertainty around perfection in terms of consent. But I think we wanted to talk about off this group, this idea of this, sort of not universal consent or universal consent system. As Ken said, ideally, you would go to one place for the whole country to find out that somebody is opted out. Now, that's a pretty big, broad, bold, concept. So that's sort of one concept of consent to share as a utility. And then we have this other concept of the utility being that when you have a robust consent process, like the one that's been demonstrated to us, that actually suddenly opens things up and allows information sharing to happen in a way that it often hasn't been in many communities, because they've been too scared to move forward. And so even at a local regional level, there is a huge benefit to having a system like this in place. There's this other concept of, can it be even bigger and broader, and something that you tap into nationally, much as though, those of us who prescribe controlled substances can now essentially see controlled substances that are prescribed anywhere in the United States, which is a huge, benefit. So we have a couple of different concepts of what this means to be a utility floating around here.
So Christine, let's build off of this also, just to kind of reframe once again for you guys the concept that both Christine and I are working on, right? So we're trying to do this integrated care for kids. So kids is an issue, right? And consent for kids is an issue, and transitions and minors and all of that are an issue. But we also we're very focused on going into the school system and into the public arena, right? We have the Agency for Children's Services. We have the medical care providers. We have the schools. We have juvenile justice. All of these are different areas. And so we are trying to really think about how can we do a consent that it goes across. And I think Ken was kind of started to show us that you can share data amongst different parties, right? And that there's a way kind of through to get the consent. But I wanted to ask Chris Alibrandi to just tell us a little bit about what she's been doing in New Hampshire, because I think it's also important to hear that there are people who have been successful. And so we really wanted to highlight that. Chris, go ahead.
Yeah, I'm more than happy to talk about it. So this is just to set the context of it, is that I work with a district project, and that's the federal funding to work to improve Medicaid systems. So I'm privacy legal counsel for this project, but I'm also the director of solutions integration. So I've had to kind of walk both worlds of what does the law allow, but then what's the reality of what can our systems do to make it easier to capture consent. Unfortunately, our technology is still on paper because we did not get to the next being able to use consent to share. But the good news is on the legal side of things, we got over the hurdles that there were. So we actually have a written consent to share. It's a release of information technically. About 55 organizations signed on to it. So if patients from any of those patients or clients or customers of any of those 50 so organizations, whether they're clinical or non-clinical, if the individual signs that release of information, they are allowing their information to be shared with anybody who's on that group list. And this is in the context of what we call our community care team. So this is a team meeting that happens whether monthly or every other week, where high need cases are presented. People who already have involvement in multiple systems. So the idea of the shared consent was that their situations could be discussed. There's no exchange of written records. It's all just for discussion and oral communication about the person. And on the form, they are consenting to release their information about, they can write in any limitations that they want to, but the purpose of it is to be able to share the person's complete story. Because what we recognized was that the law was getting in the way of what the care coordinators and clinical people wanted, and the patients themselves wanted. People did not want HIPAA to serve as a barrier to the sharing of their information so that they could get the help from the social service organizations and have the exchange of information between their clinical folks and the supportive services. So as I said, so anyone using those any one of those 55 organizations can have their patient or client sign it, and then it gets shared with a central repository. There's also room on the form where people can revoke their consent. And then that also gets reported in the repository. And then we just had that case happen for the first time in 4 years that any of those, I think it's probably up to 300 people now who have signed those consents. The first time we had a revocation. So we went through the protocol of how do we release the information out to everyone to honor that revocation and make sure that it got to all the ends of information that it needed to be. So it's been great. It's what our partners, our clinical and social service organizations asked us for, was to be able to create a situation that the patient was in control of their information, but could share it however widely they wanted. Organizations, some of which had, hospitals that had, really robust compliance departments, and others that, have smaller compliance protocols. People all got on board, and it works. And like, as I said, there are over 300 cases have been, their cases have been discussed and presented and their information shared in an environment that got them to the services they needed. And there's a copy of that release of information. I know I shared it with you, Christine, earlier today. So it will be in the resources for this NAA effort, I think, somewhere.
Yes, luckily Christine has gotten the permission and has sent us not just a PDF, but a Word document version. So it really creates a great template for others to use. But I know that I am going to share it tomorrow with my Inc. Partnership Council, not so much for the words on the consent, but for the list of the 55 organizations that have signed on, because I think, half of this challenge is just convincing people that others have gone before us and the sky has not fallen. And so I really appreciate having this example of how this type of information sharing is occurring in other parts of the country. And then I hoping to follow that, with a demo. So I think that these two pieces give us a great vision of the future, really, and where we can go by bridging the legal work that Chris's predecessors really accomplished in New Hampshire and others have accomplished in San Diego and in Pennsylvania and other places around the country, with the technology that we just saw being rolled out in 5 counties in Maryland. So it's very, very heartening, I think, to Paul and I, to really have these concrete examples of this work happening around the country.
Is there an Alibrandi cat herding award that we can pass out?
If I remember correctly, Chris actually gives total credit to her predecessors that the agreement got done and signed before she came on board.
Okay.
Yeah, I may have had a stroke of brilliance here and there, but it wasn't that one.
I have a question. So we have quite a few people who have not participated, and I wanted to hear from you guys a little bit about your thoughts about how this gets done. And let me just say I'm not that interested in the technology side, but about the process and the implementation of this and getting people to agreement, and who can help lead this? Is this something that has to happen on the legal lawyer side, or does somebody like Tony have to, you guys got to do this and mandate this? Or I know that we have others in the group who have extensive experience from the state perspective, perhaps, or a more centralized structural perspective. So I was wondering what your thoughts were on that.
I'll just jump in because no one said anything. I really like the concept of having to do this interstate stuff. My biggest challenge is that I'm in Ohio, but I'm 40 miles from Indiana, and I'm 60 miles from Kentucky. And the challenges I find, I get much better work done exchanging information within the state itself. A lot of challenges there, don't get me wrong, but my biggest challenges are exchanging information with my contiguous 7 states. Ohio's in the middle of 7 states, and so the ability that right now all we do are MOUs between different states is very challenging. So if there could be a national hub, or at least and I'm not sure if Jennifer described it or who described it, if there was the ability for this software to say between Ohio and Kentucky versus Ohio and Indiana, or California and Oregon, if this system could interact the legal complexities of those 2 states to say what works for consent, it would be so amazing, so specific for me, and great that I would know if I had a consent release, and I love the consent. If I know that I could work it with a health agency in Indiana versus Kentucky, that would be so time helpful for my court and for the providers of my community. Because I have Watson Health, which we're using now, and I have a lot of providers signed into it, but I still have challenges with other states. That would be a huge resource if it could happen that way.
It's really interesting because we just had the presentation from the Veterans Administration and the very open discussion about how, that is the one system. And I've personally worked in it for about 7 years in the VA Vista system, where if someone came from out of state, all I had to do was click in the corner and I could draw down all of their information in the VA Vista system from that other state. So I am curious as to, is there something maybe analogous to that where it's not there all the time and maybe doesn't, overload the system, but when you specifically want to, just like when I look for the opioid prescriptions or other controlled prescriptions from other states, I click the states that I'm interested in getting that information from, because, I live in a tri-state or 5-state area where people can easily cross state borders and go to other states to get medications. I'm not as worried about California, for example. So I think that's an interesting question is, does it have to be one totally giant, always integrated system, or could it be a system that you could access sort of on demand, like you do both in the prescription management systems or the VA system?
So I think it's interesting that your 2 examples operate in a different legal framework than medical information does. Generally, the VA is organized, it's a federal agency, and it has its own laws that cross state boundaries in a way that is different from traditional civilian medical care, and so it plays under a different set of rules. And that's why you can do that within the VA system. And then prescription drug monitoring programs are generally operated by state health departments, and therefore are subject to the HIPAA public health exception. And it easily overcomes a lot of the challenges that exist with this other form of data sharing that we want to do. And this is where all that complexity comes in, because nothing plays by the same set of rules. Unfortunately, the legal scheme just is not uniform at all. It depends on what type of information you want to share, who controls that information, all kinds of things come into play when you're looking at different laws and how you
ask Michael Wilkenning to comment. Michael, from your perspective of having been at the upper echelons of the how, do you have any concepts that we could bring forward here that would resonate at that level, that would allow us to bring something like this together? Looks like Michael's on mute. All right. But for Tony, what I wanted to point out to you is something very important, what that Chris said, that and you can think about this incrementally, right? And she said that they're able to share information orally. That's it, right? So they're not sharing documents. And you know, as an incrementalist, that's okay, right? And people get used to doing that. They might get used to, then they'll find ways to share documents at some point, right? And figure that out. I don't know, Chris, has there been thoughts about that?
Well, actually, yeah, your point reminds me that, so these were releases, because this was something that was started about, I think these releases came into effect like 3 years ago. So now as group trust in this huge organization, conglomeration of organizations has built over these years, it might actually now be an appropriate time to come up with an updated consent that goes a little farther. Because so much of coming up with these kind of group agreements that people sign on to, right, is the level of trust they have in each other, the level of trust they have in each other's systems, in each other's security consideration, that sort of thing. So as group trust develops, there can be more comfort with not only does the law allow it, but we feel okay about it too.
And that's why a system like consent to share, I think, has a lot of potential, because if everybody is using the same system to monitor and handle consents, that in and of itself builds trust in the way that everybody is handling the process. It's transparent, everybody knows what everybody else is doing in that regard. And so I see a lot of potential in it.
And to hook up to that, I was just going to say, Paul, to hook up to that system means that your IT folks have also done the whole review of the security mechanisms and security safeguards also, if there's any electronic, sharing of that happening too.
Matt, I was looking at you. Did you comment?
Yeah, I did. So first of all, outstanding work, Jennifer and Ken. And to put it quite simply, consent to share tracks consent. One of the pieces here that we haven't seemed to have tackled from a technical perspective is the assortment of federal and state laws associated with privacy and access, right? So one would still need to do the code associated with making sure that you're tracking these laws and that your application is coded appropriately. Have you thought about something which, imagine being able to call an API where instead of calling it to say, okay, here is Matthew Bishop, can I access Matthew Bishop's mental health information? What if you could call it and just say, hey, we're looking for generically mental health information. What are the rules associated with that? And then it would be able to tell your system, okay, this is the programmatic rule. And then the system could decide whether it wanted to share it or not. In other words, you're separating the patient data from the laws. So you don't have to have a centralized system that is just aggregating patient data.
It depends on whether the consent has to be driven by the patient or it's driven by, for example, HIPAA, TPO, for example. So yeah, there's a lot of, as Jennifer and Chris have stated and can attest to, lots of laws all over the country that some states get down to the county level for, mental health laws and things of that nature. So to do that, I think would be a pretty large challenge. That's just my perspective.
It would definitely be a challenge. I don't think it's impossible, but I think it would require essentially an organization to head an effort like that, that would crosswalk and, be able to pull that all into the system and then also keep it updated because as we all know, laws change.
Right.
They're not static.
I mean, the
But
reason.
the other part
Go-
is you have to have access to the data, right? And so, whether it sits in an HIE or several HIEs, or it sits in providers, computer systems, et cetera, I mean, at this point in the moment, right, it would probably be extremely interesting, if not difficult, to be able to touch all those potential data sources to find out if there's data there.
Well, and I think, pulling in health information exchange, I think that was originally sort of the conceptualized role of the health information exchange. There's been successes and
Right.
some not so successful
And there's
implementations.
50 or 60 of them,
It's
that are
very
built and operational. And depending on what state you're in, like Minnesota has 6 or so. And New York City, or not city, but New York State has several as well.
Oh, wow.
So it would be pretty challenging to do a query across all that stuff to determine whether there's data sitting around that I could potentially participate in. Right?
Yeah.
So there's clearly a lot more to discuss here. And as you all can see, we're about to get dropped back into the main meeting. But I think we've started some good conversation here. And I think one of our challenges is to figure out how to best continue it. But we will work on that for sure. Any
For sure.
parting words from anyone else?
And I think that this is
Really good panel.
Change have kind of carved out for themselves, right? So it's a really important place to be, and we're going to solve this. This has to get solved. So we just need to move forward and try